All right, Tracy, I just sent you the link.
All right. Oh, there it is.
All right, Tracy, I just sent you the link.
Okay. Let me just verify that it's up. Oh, that it's working. June live stream here. All right, good to go. You heard me, Jacinta?
Yep, I couldn't get myself mute.
Okay.
They're coming back in.
All right.
Mary, you need to say that again when we're public.
What's that? I'm sorry.
I said you need to say that one more time now that we're in public.
Oh, okay. I wanted to send congratulations to Amy on being honored here at the New Orleans VA as our patron of the month. So I just wanted to say not only is the OT department proud of her, but we are proud of her citywide. Thank
That's
you.
awesome. Congratulations.
For our
Thank
veterans.
you. Thank you. Awesome. We are live and ready to go, Ingrid.
Okay, great. Good morning. A meeting of the Louisiana State Board of Medical Examiners Occupational Therapy Advisory Committee pursuant to lawful notice is duly convened and called to order at 10:02 a.m. on Friday, June 28th, 2024 via Zoom virtual video. Please know any comments by the public are welcome and can be emailed to publiccomment@lsbme.la.gov. Dr. Van, please confirm you have verified the identity of all tele and video conference participants.
Yes, ma'am, we have.
Is the sound clear and audible to the public and those on the tele and video conference?
Yes, ma'am, it is.
All additions to the executive or public agenda must be made presently, as we will no longer make additions to the agenda after the close of the public session. I'm now going to review the mission. The mission of the OT Advisory Committee is ultimately to protect the public, i.e. the consumers of occupational therapy, by regulating competent practice and upholding the standards set forth by the governing rules and regulations. I'm now going to do a roll call. Members present are as follows. There's myself, Ingrid Frank, Amy LaRiviere, Kim Solari, Relina Crooks, Glenn Wallace, Mary Green Keys, Kelly Brandon. I believe that's everybody. Amy, can you confirm that we have a quorum?
We do. Great.
Also present on the meeting is Dr. Vincent Collada, Patricia Welton. Is Olivia Palong on the meeting?
No, Olivia is no longer with us. She has moved on to greener pastures.
Oh, okay, darn it. Is that Jacinta that is our Zoom administrator?
Jacinta and Miss Tracy are with us today.
So Jacinta Dutu and Tracy Morrow.
Yes.
All right. Let's see if I am able to share the screen with, I might have failed. I just need to open the the cloud share agenda. I failed to open
If,
that.
I can share it. I have it. I'm ready to roll. If you want me to
Okay,
share it.
yeah, that sounds good.
Okay, get it up for you right now.
I'm so sorry to hear about Olivia.
Oh, yeah, we had to split ourselves into two because half of us is so happy for her. It was an amazing opportunity, just living the dream. And then the other half was, how are we going to live without her?
Exactly. All right, our first item of business is to approve the minutes from our meeting of May 10th, 2024. So Dr. Van has got the minutes from that meeting up. We reviewed minutes. Patricia covered, gave us an update on the rules and where they were. We made a response to a speech therapist who manages occupational therapists about telehealth. I gave some information about the Compact Commission, and we talked about streamlining licensing. Does anybody have any edits or changes? Could I get somebody to give a motion for approval of the minutes?
I will, Amy.
All right, Amy will, and a second.
This is Raylene. I'll second.
Great, Raylene, seconds. Any public comment?
None at this time, ma'am.
Okay, all in favor of approving the minutes, please say aye.
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 Any opposed? All right, we will move on to our next agenda item then, which is really just to get an update from you, Patricia or Dr. Van, about the current status of the rules changes that we made.
Yes, we're doing the last little bit of polishing. There were potentially some potential legislation that might have impacted the rules, and so we didn't finalize everything and submit it to the register until we had see what passed and what didn't pass. Fortunately, nothing did affect us. So it's just the last little spit and polish and comb your hair, and we should be ready to go.
Okay, great. Oh, I'm glad to hear that there was no legislation that got passed that could have derailed anything we had.
Yeah, even if it was just a tweak, you don't want to send in a rule that's already obsolete. So as far as, procedures and stuff. So we're good though.
Okay. Does anybody else have any questions for Patricia about the?
I do. This is Carolyn. I'm keeping my camera off. But when do we expect them to be ready to roll?
So we're gonna do our very, very best to I'll be straight up honest. It's not likely that we can get it the deadline for publication every month with the register is the 8th of the month. And given that the state is closed on Thursday and Friday, I'm just going to be honest and say I'm not sure we're going to have the package ready to go for this month, but we will absolutely finish it within the next couple of weeks, and that will be, we'll submit it for the August register.
And then after that, how long does it take to get them ready to go?
So unfortunately, the process has the built-in timelines that I mentioned to you before. And we actually, Dr. Van and Lauren Sudeth have actually worked really hard on a really, really valuable project that's going to enable you or anybody that needs that information to be able to see a dashboard of the status of each rule in the process. But one thing the legislature did this year was it reaffirmed and moved and sort of solidified the Attorney General process that we use. And there are built-in delays of 30 to 90 days, depending on what stage you're at. We usually say 6 to 9 months is an optimistic, is a reasonably optimistic time frame from start to finish, from notice of intent through the public hearings, through the reviews, through the comments, through the legislature making up its mind whether it does or does not want to have an oversight committee. Your rules are not controversial. I don't see any hiccups, any reason why it should get stalled in the process. But unfortunately, there are these timelines that we can't speed up. So we usually say about 6 months, start to finish is a really good result.
Okay, thank you.
Yes, ma'am.
Oh, Carolyn, you do sound bad.
I'm actually better today, so.
Oh, wow, that's not saying much, huh?
Uh-uh.
Okay, thank you,
So,
Patricia.
so we're hoping February, would that be 6 months? Maybe February?
Yes, and honestly, potentially, possibly, depending on what happens with things like, special sessions or constitutional conventions or whatever else the executive branch might have lined up for us in surprise moves. But yeah, I would say that is a very reasonable, after the first of the year is a very reasonable time frame.
Thank you.
You're welcome.
Okay, we are now moving on to our first order of new business, which is the advisory opinion on best practices for use of telehealth by OTs. This came up in our last meeting in response to the speech therapist who was supervising OTs using telehealth, and we had identified as a group that maybe an advisory opinion is needed. And so I created this draft, and basically I'd like us to go through it. I am wide open to edits, changes, deletions from any of the members, opinions from Dr. Van and Patricia. I've got my Word document here that I can make changes on as we talk. So Dr. Van, if you could just start it at the beginning, I guess. I did send this out ahead of time so people could read it, but we had no conversation about it, but just so that people could have already been familiar with what I wrote. So I'll open it up. We'll just start at the top. I did an intro that talks about why we wanted to make this advisory opinion, that there were questions raised. I gave some background about the act, and that I was expanding now on Rule 2, recommending best practices for OT, for delivering intervention by telehealth. So just starting from this intro section, which is 4 paragraphs long. The whole thing's kind of long. So
Yeah, I was thinking, if you don't mind, I'll go through and maybe substitute one word for 2 or 3 where it's appropriate as we go along. I mean, I'll run it by you first, of course, but as far as the substance, that's not. So the only thing, Rule 1 and Rule 2, those are subparts of 1223.4.
yes.
Okay, because we wouldn't really call them Rule 1 and Rule 2. We'll just redefine it as whatever subpart there. You know what I'm saying? There's nothing, we don't refer to them as Rule 1 or Rule 2.
Gotcha.
So if it's, I'm not looking at the rules right now, but if it's section 1223.4, probably A and B is what it is, maybe.
Okay, I don't remember anymore what I saw.
Yeah.
I wrote this like 4 weeks ago.
Um, yeah, I don't know. Probably won't say expand, because we can't expand the rule except by rulemaking process. So we would use a different synonym, like will further discuss or elaborate on or something like that.
Okay. That sounds,
Expand sounds like we're actually enacting more parts to the rule.
all right. I'll go. I like that.
What is, okay, so OTAC uses AOTA official documents when reviewing cases. What does that mean?
When, if somebody from the community complained about an occupational therapy practitioner, and it had to do with the way that they were assessing or providing intervention using telehealth or anything else really, we would use AOTA official documents to help us as OTAC review whether the person had acted unethically or had I guess not used a common standard of practice or judgment
Okay,
in their intervention or assessment.
okay. So instead of uses, I might say something like relies on or is guided by.
Okay. I like that.
How do they use the AOTA Code of Ethics to determine if the client is best served?
The code, that principle 1A of the Code of Ethics just states that OT personnel have to provide appropriate evaluation and plan of intervention specific to the client's needs. So that's part of our code of ethics. And if somebody has chosen to use telehealth for convenience and it's not the most appropriate means of providing the therapy, or isn't the best way that's specific to the client's needs to deliver
Okay,
then that
so
would
is
be
this, yeah, is this paragraph some, page 5, what you're quoting is the position paper at page 5?
let's see this.
Or what does the page 5 refer to? Or is it page 5 in the?
Yeah, I don't have my good reference there, huh? My reference
Well,
is
so here's my thinking is that it's a little bit backward. It could be conceived theoretically, it could be a little bit backwards because if you say ethics applies to everything and it's the overriding principle, you might talk about the ethics first and then talk specifically as to telehealth, then go from the ethics that applies to everything and then the specific requirements that are on the telehealth.
so yeah, I'm not actually sure what I didn't reference that very well in terms of page 5 because I have 3
It looks
references.
like it looks like it must be in the AOTA.
The code of ethics. I'm not
Yeah,
sure.
because you say 2015. Well, I
Yeah.
don't know. Yeah, we don't know.
either.
I don't know
I
if
have
that's
3
page 5
references.
of, yeah.
I have 3 references at the bottom, so
Anyway, if that makes sense at all, if that was a direct rephrasing of what's in that paper, then you can leave it like that. But I would say if they were gonna think about it, first of all is ethics first and foremost, and then we have these specific requirements relative to telehealth. Wouldn't you, or is that not?
no, that I think well, let me just so the first sentence that I have, as stated in the position. Oh, I see. It's the position paper. I'm referencing the position paper that from AOTA, the AOTA's position paper on telehealth.
Okay. So that
Um,
middle reference to AOTA 2015A, page 2, what is that?
That's within that quote from the position paper, they
Okay,
are referencing the code of ethics.
okay,
Yeah. So it is a direct quote off of the
okay,
position paper on the use of telehealth.
okay. So the position paper on telehealth emphasizes the requirement that the therapist assess each client using clinical judgment and the code of ethics. Okay,
It might be helpful if you'd send all those documents to Miss Patricia after the meeting.
Yeah.
in summary, the use of telehealth test is made like a policy, but should be based on consideration. Okay. So I like everything. I think it's excellent. The only thing I might suggest to you, if you're not opposed to it, is I might tweak that little middle paragraph just a little bit and send it back to you to see if it makes, if it doesn't do injustice to what you're saying, but it makes it a little more clear to a layperson like me, which this isn't going to lay people. I understand that. Of course, it's going to the practitioners, but would you be okay with that? And you're always free to accept or reject anything that I suggest.
Yeah, that's fine.
Okay.
So with the next page, starting with specific considerations for telehealth decision-making, client safety of their best practices, did I get too picky for an advisory opinion or did I get too
No,
deep?
no, I think this is fine. Oh, I mean, me personally, anybody else may have a different view.
So yeah, I'd like to now hear from other folks on OTAC about any.
Shut up, Patricia.
No.
I think you're too picky about it. I think Glenn had a comment in the chat about something that I was kind of iffy about on the e-helper.
Um,
What I'm submitting in the chat is by no means meant to be um, uh, verbatim what we accept and put into your paper, but I felt like how like what you were building up to as far as like the purpose of this document is to really set a standard for what e-helpers can do and what they can't do based on what the job of the OT is and what their professional responsibilities are. And I feel like while we kind of say what the e-helper, a little bit of what the e-helper does, we don't say like what they're not meant for. And I still feel like that could be a helpful position for OTAC to take. And so my comments that I put in the chat, I'll read it just so that we have it on
yeah, read
video
it.
because I don't know if the chat carries over to what gets recorded or whatever. So
Yeah, please read it.
yeah, so I said e-helpers assist in the delivery of in-person quality occupational therapy services. They are not meant to act as a conduit of skilled occupational therapy services, meaning they're not an in-person replacement for the OTP. If the OTP is reliant on the e-helper, parentheses, rehabilitation technician or otherwise, to acquire specific knowledge and or data that only an OTP would be able to acquire in person, the OTP would be utilizing the e-helper in a manner inconsistent with the standards set forth by both the AOTA and the Louisiana Telehealth Act. So I just felt like it was a chance to be a little bit more direct in terms of, what how we really don't want e-helpers to replace OTPs. I guess that that's kind of just my 2 cents, and anybody's free to pick that apart or agree or disagree. But I just felt like it needed a little bit more. Just personally, I felt like we maybe needed a little bit more about a little bit more about the e-helper in that way.
I think that's very helpful from a person who doesn't utilize telehealth much. I think that was helpful clarification.
Glenn, I'm not able to copy and paste that chat in that
Okay.
chat language, so you'll have to email it to me because I don't know
Sure.
why I'm highlighting and trying to copy and it's not working.
Sure. I'll email, and if you need to like revise it a little bit, it's totally fine. I was just, as with most things, I feel like the best way to try and get to the meat of what we're trying to say, and the best way is just to start talking about it. So if it needs to be revised at all, that's totally fine. But I'll send you what I like, the rough draft of what I wrote right there, and then I guess if you want to use it or cherry pick from it, it's totally up to you. It's fine.
Okay. Yeah, we'll do that.
But yeah, I'll email it to you right now.
What about other OTAC members with any part of it that you think could go, or that needs to be changed, or that you think works?
I had a quick question. About, let me see. I made a note, hang on. About the consent, the obtain verbal informed consent. Do we, I mean, I know that's just should that be each session or one time? I don't know how, but I think that would be a question that people have.
I agree. That one is, and I don't remember where a lot of this came from, like a session that Darby and I had, I don't know, a long time, months and months ago, where we sat down and when we thought we were going to be putting information like this into the rules, and then for whatever reason we didn't. And I don't remember where we necessarily got all of the practices that I wrote down. I mean, I do have my references at the bottom, but off the top of my head, I don't know if that informed consent, it doesn't feel like something that would have come from the AOTA position paper. So I don't know where I got. Dr. Van, do you know if any other, like physicians, for example, or any other practitioners, are they getting any kind of verbal informed consent from the client agreeing to the session being over telehealth? You're on mute, Dr. Van.
Thank you, excuse me. They are getting consents for treatment. And so the issue really becomes one of, you can extend that for the course of the treatment involved in the particular problem. But the bigger concern is, while we talk about use of HIPAA compliant a few paragraphs down, I need to make a comment that we probably need to figure out or advise people that the ability to record the entire HIPAA compliant exchange is better than summarizing it, but nonetheless, it should be an option for anybody to do. I think the issue is, if you're giving treatment based upon what you're doing, then you should consent to the treatment. The patient should consent to the treatment. Now, the bigger issue is, that's the kind of stuff that most of the docs are doing in advance of the visit. So what happens is, for example, when I get my telehealth visit with my cardiologist based in Austin, we have I have signed a consent that says I consent to the treatment evaluation and recommendations that are be prescribed, and that I do that in advance. They give me a time to make the phone call. I show up on the Zoom with the doctor or the APRN, usually both. And then whatever they tell me to do, I'd make the note to do it. They put it in the chart and they've got it. So again, I think the key is, if you're giving treatment, you need to be able to consent to the treatment.
wouldn't, I mean, y'all let me know if I'm wrong about this, but in occupational therapy, outpatient practice as an example, they are getting a consent to treatment signed on the front end. And there's a blanket consent to treatment. So maybe this asking, once you get on the telehealth, getting another informed consent just to do it via telehealth might not be necessary if you've gotten a blanket signed consent to treat ahead of time, which most outpatients do, correct? I'm right
And
about
that's
that,
what
right?
most physicians are doing with telehealth today.
Okay. Dr. Van, in the consent to treatment, would you recommend that the language of the consent to treatment include a line about that treatment might be via telehealth?
Well, I think that we probably need to get to an understanding, and I use this all the time. Telehealth is a tool to practice good medicine, good occupational therapy, or anything else. So just like you would get a consent to treat your patient if they were in your office, you should do this for that. But the tool is allowing you to do things that you couldn't normally do in some cases. But if it's not, so you're not, we don't necessarily, unless there are a few little exceptions in some of the state laws that talk about sensitive examinations and things like that. But if you get a consent to treatment, we don't generally say that unless there's a unique procedure involved, like we're going to treat you for your uh, painful knee, but what we're going to do in addition to your physical therapy, range of motion exercises, and everything else, we're going to do an injection. So you're going to get the injection is going to get a specific consent, but the
Yeah.
overall treatment's going to be part of a plan that you're going to be putting together. And I think that's what you need to be consenting to.
Okay, so it sounds like we could remove that practice of having to get a verbal informed consent specifically for the delivery of service to be via telehealth.
Is that not asked for at the start of every session? Just to confirm that like the person is aware that this like in the sense that whenever you call a customer service line and they tell you this call may be recorded for training purposes, like I mean I feel like it's I feel like it's the same formality where you tell the person this treatment session, like, do you consent for this treatment session to be performed via telehealth? And then they say yes. Like I feel like it's that same, while it is while it's this rule that we're discussing on our end, and we know that we have like general consent forms that get signed for the provision of medical care or therapy services in a clinic setting like that, whenever you sign all the papers when you come through the front door, i feel like that is meant I feel like the intent behind that is for like that kind of informal formality for lack of a better word, um because things are being delivered not face to face, just so that you can have it documented that that person was aware that that treatment session was provided via you know what I mean. I
Well,
now
let me
I, I'm sorry. I was just gonna
I'm
say
a little
I've
unclear
never.
on something. If you could just explain something to me.
Sure.
While telehealth is a broad range of technologies, are we moving away from televideo and the potential for recording and moving into phone calls?
No.
It,
So
there, there,
if we're
there's
not going to
never a
move into phone
situation.
calls, and we're going to do this just by video. Like I said, if you record that, you just say, just want to remind you that we're going to be recording this, and it'll be part of your medical record. And then you've done everything you need to do because you're just reaffirming the consent that they gave you earlier. Again, a lot of this would be really up to what you think you might want to talk to your potential medical liability carrier, because that's where the issue of consent is going to be. We expect you as professionals to do what is best for the patient, and if that's needed. But in terms of what you need to do for your professional liability carrier, we can't express an opinion about that. That's giving legal advice, and we don't do that. But I think the issue is, if you're going to record the thing, if you just say, "Hi, good morning. Just before we get started, I want to remind you that you signed your consent to do this by televideo, and we're going to record this, and it'll be part of your record. Are you comfortable with that?" Yes, and you can move on.
Dr. Van, I didn't envision that telehealth, an intervention by an occupational therapist with a client by telehealth will probably be a solid 45 minutes long. So, I mean, are you suggesting that the entire session should be recorded? I mean,
For
normally,
your protection, I would. But if you choose not to, that's your decision, but you better have very, very good notes.
My earlier statements were kind of made, the asterisks that I want to put on the end of my earlier statements is that I number one, I've never used telehealth. So it's something I'm aware of, but it would be novel to me in that way. And then number two was going to be, it might be beneficial for us to just have a conversation with somebody who uses it, just to confirm. And by me saying confirm, that's not me saying that I disagree with anything, Dr. Van, that you've said or anybody else, but just to get the, like, boots on the ground, like, information for what people are doing who are using this. That's all. And that's all I'll say on
And
that.
again, there are two environments. They're going to be the employed OT that's doing it as part of their employment for whatever institution that they work for, and they would govern what they expect with regard to consent. However, when you're now the entrepreneurial individual practitioner, then you really need to contact your professional liability insurer and ask them what they think is best to protect you. Because they're the ones that are going to make the decision later on if there's an accusation of improper care. Oh, well, why didn't you have this done? And well, if this was recorded, we'd be so much better off. Or, oh, so again, I think it's going to be highly individualized based around who is paying the bills and who is going to be responsible for the professional medical liability. And Pat, jump in if I'm stepping on part of my anatomy here, but I think the employer is going to make one decision, and the individual entrepreneur and his professional or her professional liability insurer is going to make the other decision.
Ingrid, I will say that here at the VA, we do not record our sessions. That's not our practice normally to record our sessions. Amy, has there ever been an instance where during your video, your VBC visits, have you been asked by the program to video? We've never.
No, I do a lot of telehealth stuff. It's more of a assessment application processes, and never, we do have to get permission and ask if they're in permission to do the visit, and then also make sure it's a safe environment and see where they are in case of an emergency to be able to get help, but we do not ever record them.
And since Amy and Mary, since you guys both are a little more familiar with telehealth, this part about obtaining agreement or consent to accept the session over telehealth, is this a natural thing? Is this a good thing? Is this unnecessary? What are y'all thoughts on that?
I think it's necessary. We have a standard practice where all VBCs are done pretty much the same way. So there's a common language in the VA of what is being said by each clinician prior to the VBC session. Just like Amy just said, we get the verbal consent, and then we make sure their environment is safe, and then that we do have a plan in place with them if there should be an emergency while we are doing the VBC session.
This is Raylena. I also do telehealth, again, within the VA system, but I think to give credence to what Dr. Van is saying, I think we're talking about two fairly separate things. Telehealth within the VA system is very templated. It's very standardized. We have to go through trainings in order to standardize kind of like what Mary was saying, our telehealth sessions and making sure that all the elements are there before we even start our session. But in regards to what Dr. Van is saying, I think he was more referring to the independent practitioners and covering their liability and things like that. I think the two are separate. I'm not an independent practitioner. Both are telehealth, but the telehealth that we provide here within the VA, again, is very, very standardized and very just very regimented as far as and it's all set out for us ahead of time. So I think where you get into question is where you have the providers that are out there that don't have that standardized already.
I agree.
And I would add one other thing. While you may be licensed as an OT in Louisiana and work at the VA, the Board of Medical Examiners does not get involved in and govern any of the practices at a VA. For example, you may come from Texas, have a Texas OT license and work at the VA in Louisiana, because we do not regulate the work in the VA or regulate those people that work in there. It's when they work outside of the VA that we would be. So if they had a secondary practice, or if they did some moonlighting at one of the hospitals here in town on the weekend, that's where we would have regulatory authority. But in the VA, we do not exercise any regulatory authority by and large, because it's a federal installation with a federal assignment, and we stay out of that.
Interesting. Okay, so it sounds like everybody feels like the things under other best practices are appropriate. There's one more that you can't quite see if you, yeah, be proficient in the use of telehealth technology was the other. Are we missing anything? I mean, it sounds like everybody's okay with what's in there. Are we missing anything?
Well, just for clarification, and Miss Patricia might want to comment, maybe I'm overstating the obvious, but I routinely get calls about people saying, well, how do I do telehealth? And I want to do telehealth out of Texas. I said, well, we don't regulate your practice in Texas. Your license and rules of Texas would apply. So I think we need to be clear that this advisory opinion is for anyone from any state who is practicing telehealth in Louisiana, because they would have to comply with our rules, our regulations, and our licensure requirements. So obviously, we are anticipating that within 24 months or so, maybe we'll start having compact licensings being issued, and those compact license people would have to comply with our advisory opinions and our rules for the practice of occupational therapy on patients that they see in Louisiana, even though they are living in Boston, because Boston's rules do not apply to Louisiana patients. So I think that's important. We ought to figure out a way to say that clearly at this point.
Okay. So what you're saying is if somebody is licensed to practice OT in Louisiana, but they live in Massachusetts and they're doing telehealth with clients in Louisiana, that it needs to be clear that this advisory opinion applies to you.
Correct. But it does not apply to a Louisiana OT that might have a compact license in the future and is treating a patient while living in Louisiana, that the patient lives in Wisconsin, because Wisconsin's rules would apply.
Okay.
So basically, think of it this way. The rules and licensure requirements are based around the residence of the patient. And, everybody, whether from the FSMB on down, is now working to come with definitions of how we determine residency. And they're talking about the standards of tax and everything else, but the important thing is if that's where the patient lives. Now, let's give another scenario. Let's say you are seeing a patient in Louisiana and that patient decides to go to school in Alabama, if they maintain their residency in Louisiana and are only away at school at Alabama, most states would allow you to do it, but all states do not. So I need to tell you that this is highly nuanced, it's ever evolving, and I know what we're trying to say, but we have to say that a statement should be made that the rules of the residency of the state would apply, and the guidance should be sought from the state licensing authority where the patient resides. I think that's important for everybody to understand.
Okay.
Because even doctors I'm going to be honest and say, I get a call a week from doctors about this all the time.
Got it. All right, I'll add something like that in that introductory section.
I just have one question, and I don't know if we need to do this or not, but I'm just thinking that, let's see.
You want
There-
Dr. Mann to move the document?
No, the use only HIPAA compliant communication interfaces is, can we give some examples of that? I mean, I don't know if that's
Well, for
appro-
example, Zoom is not considered HIPAA compliant.
right.
Team is not considered HIPAA compliant. That's why most of the televideo work is being done on platforms that the hospital provides, the medical record system provides, that are HIPAA compliant, and that's what we expect you to use. And most of them actually allow for recording. I know I still maintain a medical record system, even though I don't treat a lot of patients. But for those few little patients that I treat for free, I keep that kind of thing available. And I can tell you that if I do a televideo visit, I record the entire thing. And it's just so much easier because then I don't have to basically write a record. I just plug in the video into and a quick summary, and I don't have to go through a lot of the other things that I did. But again, I think the key here is that though a lot of those decisions of what HIPAA compliant platform are going to be made by employers or the entrepreneurs, they set up their own medical record keeping system.
I think,
Okay.
Carolyn, to your point, I don't know that we should name any specific or give examples, but I think it would be good to say, to add to that sentence, use only HIPAA compliant communication interfaces, add a sentence that says many or currently many common video conferencing things, are not considered HIPAA compliant, just to put them on alert, something like that.
Right. Yeah, because I wouldn't know that unless I was talking, I've learned that
Yeah.
from Dr. Man. I didn't know.
Yeah. So if we just add a sentence that's say many common video type, something like that, platforms are not HIPAA compliant, and they'll know, that kind of puts them on alert to check theirs.
Right. I think that's a good idea.
Okay. And you don't want me to give examples of ones that are not, like Zoom?
I don't, because if it becomes a cottage industry, people might fix them and it might change.
Okay.
You know what I'm saying? We want this to be a living document, and so we're basically just saying double check for yourself. We can't tell you which ones to use or not use, but you need to check.
And
Okay.
Zoom may someday be HIPAA compliant. Who knows?
Right. That's what I'm saying.
Okay, so I put after that statement, use only HIPAA compliant communication interfaces. I then wrote, currently, many commonly used video platforms are not HIPAA compliant. That's so without giving any examples. I just wrote.
That works for me, unless y'all disagree.
Ingrid, do you need to put the word references above the references?
Yeah, that's a good idea. I added that to my Word doc that I've got over here. Could you bring it back up, I guess, Dr. Van, just so people can see if there was anything else, even from page 1 that it's awfully long, but I couldn't figure out how to make it shorter. I hope that, OTPs in Louisiana who are using telehealth, that if they get this as an email blast through LSB and me, that if they are involved, they'll say, oh, I need to read this, and read the whole thing. But if we,
Yeah, I would think like maybe once it goes out, OT departments and OT supervisors, if nothing else, they will probably pay attention to it and then communicate it downward.
Yeah.
Just the only thing again, I just promise I don't mean to be nitpicky, but it seems kind of weird to put be proficient in the use of telehealth technology as the very last thing in best practices. That ought to be the start of anything. If you're not proficient in the use of telehealth technology, you shouldn't be doing it to begin with. But I don't think it needs to be in a best practice. I think it should be up somewhere up closer, more like it goes without saying kind of comment.
okay,
Just give that some thought, and otherwise it's not wrong.
right,
It's the tail wagging the dog. It kind of seems like a little bit to me.
okay. I'll look at where we can put that higher and different.
Do you
Well,
want to kind of little cleanup things, or you want to just wait?
oh, no, you can give me any cleanup right now, and I mean, Patricia also has some cleanup,
Yeah.
but yeah, what else?
On the second paragraph where it says at the end where it says underserved areas, and that period should probably go inside that quotation mark.
Okay.
You see?
Oh yeah, I see it. My quotation mark is in the wrong spot. Yep,
Right.
good.
And on the last, the second, no, on the bullet point and under other best practices, is it clearly document, on mine, it shows that there's a space between document the.
Yeah,
Sure.
there is.
Yeah, I saw that. Yep, got it.
Okay, it seems like, there was one place. I mean, it always says the, AOTA, but there was one place and I can't find it now where it only says American. So I don't, American Occupational Therapy Association. I don't know if we need the word the there.
Okay, let's see.
Since
It's
this
got
is going to probably be modified some, I think thank you for the suggestions, and Pat's going to kind of clean this up and then we'll bring it back to you before we go any further with it. But Pat's going to put it in what we would probably say, board language and format, and then we'll let you see it.
Yeah, Carolyn, I don't see it right now, but
It's not
Okay.
the reference section, is it? Are you talking about the reference section?
No, I don't remember
Okay.
where I should have marked it, but I guess I just skipped that one.
We'll find it.
Give me about 15 minutes, I'll call it.
Thank
okay.
you.
All right, well, if nobody has any other changes right now, I'm going to see how about putting, the being proficient and making that more like that goes without saying kind of a thing. Adding the language to the first section, the intro section, about who this applies to. And then send that to Patricia, and then Patricia will do her thing, and then we can vote on it in our next meeting.
Yeah, and we can circulate it ahead of time. Just don't confer among yourselves. If you have something specific, either tell Ingrid or tell Dr. Van or myself, and we can make those changes. We can put those alternates for your consideration at the next meeting. But yeah, but that's fine. And again, mine are just little ticky-tacky little wordsmithing kind of things. There's nothing wrong with the way it is right now.
All right, our next item then is about our committee. We don't really, we only have one person. Glenn is expiring at the end of this year, but it's only his first term, so hopefully he wants to stay. But yeah, what I want to find out is if we don't actually have anybody who at the end of 2024 has to get off of OTAC because they have completed 3 terms. I thought I was going to have to get off at the end of 2024. But then when I went back and looked at the paperwork, I see that my final term does not end until December of 2025. So we don't have anybody who has to get off at the end of 2024. But I would like to know who would like to get off at the end of 2024 so that if we do need to advertise for some positions, we can get started on that and, you know, use some meetings in the fall to review resumes and pick who will be replacing people in the year 2025, starting January 1, 2025.
I thought mine ended in 2024, but I see I'm only in the middle of the second term. So I was like, so I'll stay on, but I would like to get off as secretary if somebody would like to take secretary over.
All right. Thank you for staying, Amy. Glenn, your term, your first term would be up. Are you intending to stay?
Please.
I can't wait to get out of here. You guys are just, it is just draining me emotionally and spiritually. No, I'm just kidding. No, I am more than happy to continue serving and being a part of OTAC.
Great, okay. Anybody else that is burnt out? I mean, believe me, there's no judgment here. And also, if you don't want to say it in public, you can email me. I guess that's all. That's fine too. But I
Ingrid,
was.
this is Raylene. I'm staying. I'm staying. I just want to see if someone can change my region. I'm not from New Orleans. My region is Pineville
Okay, great.
on the list right there.
Oh, that's actually good. That's great.
Mhm.
I thought so. You know, I looked and I was like, how did I end up in New Orleans? We have so many people in New Orleans. I've
Yeah.
always been from up here in Pineville. So I figured that would help us out a little bit.
Absolutely.
Thank you.
Awesome.
Ingrid, mine says administrative. This is Kelly, and I don't know if that was for a reason or if it should say education or academia like yours does.
Yeah.
I changed it on the shared one, but I didn't. This might just be the one you sent though.
I see we've got Carolyn as gerontology and she's in
Yeah.
in education also, but that's good because we kind of need, you know,
Yeah.
gerontology in one of our areas.
I didn't know what administrative.
I don't know either. Or what? Yeah,
I
because that's
can,
not one of our things, is it?
I don't think so.
That's
can
Nancy Kim as technology. That's far from where I am. I'm in pediatrics.
Kim is in pediatrics. Okay. Kim, we're gonna change you to pediatrics. Oh,
I'm gonna pull up the rules real quick because I don't remember what we're required to have.
me neither.
You pull up the rules, I'll be changing them.
Can you also, for me, I have two things to change right there also.
All right, let's
Um,
go ahead, okay?
I am certainly in mental health. It's not a question of whether or not I'm adult
Oh.
physical disability or mental health. I work in mental health, and then I live I live in St. Francisville, but I practice in Jackson. I don't know if there's like a specific region that you want to use that, but like I'm not
No,
I
it
don't live
just
or
calls
work
for
in Zachary.
geographical diversity.
Yeah, so I don't live or work in Zachary. So whichever one you want to choose, St. Francisville or Jackson, would be the most
I would do Jackson.
appropriate. Okay, cool.
So what the areas we're required to have are administration and management, developmental disabilities, education, gerontology, mental health, physical disabilities, sensory integration, technology, and work programs.
Kim can be sensory integration. If there's not a pediatrics category.
Yeah, that's the one. In our new rules, we changed it to pediatrics from SI, but right now it does still say SI.
Okay.
And so it's administrative slash
Management.
management. Um,
Kelly, do you fit anywhere better than?
Mary Green Keys, Mary, you're definitely administration slash management, correct?
Yes.
Yeah. So Kelly, do you have like a different sort of I guess
I mean, education, I was peds, but developmental disabilities would be,
okay,
I could fit into that category too.
great. Kelly's developmental disabilities. Thank you.
Are we talking about our experience or where we currently practicing? Because I
No,
mean,
it just,
physical.
yeah, no, it just says proficient in and representing each of the following areas of OT practice.
Okay, I mean, you could keep me as proficient in adult physical disability because I've worked in an ICU for about 6 years. Like, I mean, acute care in the hospital was about 8 collectively, but
Okay.
however you guys would like to qualify that. So, I mean, I do have that experience and I could go work there tomorrow, but currently I work at you know, the
Right.
state-run mental health hospital here in Jackson.
So you
Yeah,
really
I think we should probably keep you as both, and that works
Okay.
well.
Okay. Yeah, sure.
So the only thing we're missing is, oh no, we have technology. Okay.
No, I'm not technology.
Oh, you're not technology. That's what you're
no.
saying. You're
Yeah.
gonna, yeah.
It was sensory integration. But we are, and we're missing work programs, but that again, that's one of the ones when our new rules take place, we got rid of that one.
All right, so don't stress over
I'm not
that.
stressed out. Yeah.
Well, does technology count for those members who work a lot? Like, even though you said, I forget who it was that said they work at the VA, but a lot of what they do is through telehealth. Like, even if
Yeah.
it's at the VA, does that count for technology?
Yes.
Yeah,
Yes.
that's me, Amy.
Okay.
And does anybody want to change it to secretary? While we're changing things? We could wait till the end. We could wait till the
Yes.
end of the year, but
Yeah. We're gonna get we'll get you switched off of that, Amy.
And
So-
keep in mind, whoever steps up for that, you will always have the YouTube video to go back and supplement your notes if you need it.
I always would forget about that. I do still forget about that. And it looks like we don't really have Kathleen's her specialty area of practice on here,
She's adult.
nor her geography, and she was not able to make the meeting today.
She's adult rehab and she lives in Monroe.
Okay, there we go. So that would be adult physical disability and Monroe.
Okay.
Great. All right, it looks like right now we don't have to, we're gonna be able to stay stable. That's great. Fantastic. I'm happy. I'm very happy. That was all we had on our agenda, unless anybody, well, we're not allowed to add to the agenda. So I guess that was everything we had on the agenda. Our next meeting is Friday, July 26th at 10 a.m. Which at this point, we probably will have the advisory opinion about telehealth for sure on that agenda. I'm not sure if we'll have anything else. But hopefully we will have the telehealth advisory opinion for us to vote on at that meeting. And do we have any public comment?
No, ma'am, you have no public comments at this time.
All right, then the meeting is adjourned at good Lord, my time disappeared on the computer.
11:06.
Thank you, 11:06 a.m. And I hope everybody has a good rest of their Friday.
Everybody have a safe weekend. Thanks for all your help.
All right, bye, y'all.
Bye.
Bye.